Hi guys, welcome back to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about pulmonary edema, and then we'll add some tubes that we see on chest radiograph in an ICU patient. So pulmonary edema is actually just the accumulation of fluid in the extravascular compartment of the lungs. The radiographic severity of pulmonary edema typically progresses through 3 stages, and these stages correspond progressively to increasing pulmonary venous pressures. Now, vascular redistribution is the first radiographic sign of increased pulmonary venous pressure. On imaging, we'll see that the upper lobe vessels would have a larger caliber or even an equal caliber to the lower lobe vessels. Ideally, the upper lobe vessels appear smaller in caliber than the lower lobe vessels because of the action of gravity. But in what we would call cephalization, the upper lobe vessels would appear larger or even equal to because of the upper lobe diversion of blood with increasing pulmonary vascular pressure. This leads to what we call the stag antlers sign. So in this image, we see that the heart is enlarged. There is mild blunting of the right costophrenic angle. That suggests that there might be some pleural effusion here. Then we can also see that in the minor fissure here, there is some fluid extending into the minor fissure here. As you can see, it's thickened. There's also upper lobe venous diversion, evidenced by dilatation of these vessels that are moving into the upper lobe compared to the lower lobe vasculature. And just for the sake of completion, we can see some lower zone opacities as well. Now, the upper lobe vascular dilation we described is what is giving us what we have come to call the stag antlers sign. Then interstitial edema is the next stage as the vascular pressure increases, as I earlier illustrated. So interstitial edema arises almost exclusively due to an increase of the pulmonary capillary hydrostatic pressure, which occurs most commonly in left-sided heart failure, and thus it's a key element of cardiogenic lung edema. The increased pulmonary capillary pressure leads to an excess filtrate filling the bronchovascular interstitium, and that on imaging is what we would see as peribronchial coughing and septal thickening. And then you would also have lymphatic distension. If you remember, we mentioned that the lymphatics are in the periphery of the secondary pulmonary lobule, and as the lymphatics gets distended, you would have the interstitium also being more prominent, and that will manifest as the curly B lines on plain films. So this radiograph demonstrates moderate enlargement of the cardiac silhouette, and we can also see some stenotomy wires here. There are also increased interstitial markings, if we look closely, that have been pointed to by the yellow arrows. There is one curly B line here. In fact, there are multiple of them. And this chest CT shows smooth interlobular septal thickening, and that also corresponds to the curly B lines that we saw on radiography. There's a mild background of ground glass attenuation, which likely corresponds to early alveolar filling, which is the next stage after interstitial filling with increasing pulmonary venous pressures. Interstitial edema can quickly progress into an alveolar pattern where the alveolar spaces become flooded as well. This edema typically has a perihilar distribution. Pleural effusions and cardiomegaly sometimes also are present. Now, the CT findings of alveolar pulmonary edema include dependent or central ground glass opacification and interlobular septal thickening. So it makes sense that the septi will be thickened because it's a progression. It's progressed from vascular redistribution to interstitial edema, which we would see as the septal thickening, and then now it invades the alveolar, thus giving us the ground glass opacification. This alveolar edema is also usually symmetric and usually dependent. Now, a classic cause of asymmetric pulmonary edema, where you would have isolated right upper lobe pulmonary edema, is acute mitral regurgitation, secondary to some myocardial infarction or maybe papillary muscle rupture. You can also have alveolar pulmonary edema as a complication of aggressive thoracosynthesis, and this is caused by rapid re-expansion of the lung that was previously in a state of collapse. Maybe it was in a state of collapse for more than 3 days because of some massive pleural effusion, and then you rapidly decompress or rapidly remove all that fluid, and thus the lung expands rapidly. That negative pressure that is created within the alveolar kind of sucks in fluid from the vasculature, leading to alveolar pulmonary edema. So in this X-ray, it shows bilateral perihilar opacity in the batwing configuration, which is typical of acute pulmonary edema. Kelly B lines are also seen, consistent with interstitial edema. Then on this CT, it shows S-space opacity in a central peribronchovascular distribution, which is classic of acute pulmonary edema. There's also smooth thickening of the interlobular septi in the lung bases and in the apices as well, which is consistent with interstitial pulmonary edema. And this correlated with the radiographic findings we saw earlier of Kelly B lines. Now we are going to talk about some supporting devices in a patient who is in the ICU. So first we'll talk about an endotracheal tube. So we are basically talking about the correct positioning of these tubes. Now the endotracheal tube tip should be approximately 4 to 6 centimeters above the carina, with the neck in neutral alignment. When you directly intubate either one of the mainstem bronchi, either the right or the left, you may cause complete atelectasis of the unintubated lung. Because, example, in this X-ray where you have the right mainstem bronchus being intubated, this is the tube. This yellow arrow is the tube which is within the right mainstem bronchus. This is the left mainstem bronchus. In a case like this, if this patient is mechanically being ventilated, only the right lung is involved in gaseous exchange. The left lung would have all its oxygen absorbed, and then after everything has been absorbed into the vasculature, there's no air coming back into the lung to continue respiration. And so the alveolar will then collapse, and it's going to be all the lobes of the left lung that would collapse. And this is an emergent finding if you see the endotracheal tube in one mainstem bronchus. Ideally, it should be about 4 to 6 centimeters above the carina. This is an abnormal position. The other tube we'll talk about is the central venous catheter. The tip of a central venous catheter should be in the lower superior vena cava or the cavo-atrial junction. In about 1% of cases, you may have azygos malposition of the central venous catheter. And this azygos malposition is associated with an increased risk of venous perforation and catheter-associated thrombosis. And if this is found, repositioning is recommended. If it's a dialysis catheter, it's recommended that it should be inside the right atrium. So in this frontal radiograph, we see this left-sided pick causing medially at the confluence of the brachiocephalic vein and the superior vena cava around here. And the lateral radiograph shows its course as it curves anteriorly before heading inferiorly and then posteriorly into the azygos vein. It can only be in the azygos vein, looking at the course it takes. The azygos vein runs along the vertebra and then moves anteriorly to empty into the superior vena cava. So for the tube to take this bend, could only be in the azygos vein, and this occurs in about 1% of cases. Finally, we'll talk about the pulmonary artery catheter. That's also called the Swan-Ganz catheter, and it's used for a number of things, including measuring pulmonary arterial pressures, among others. Now, the tip of a Swan-Ganz pulmonary artery catheter should be in either the right or the left pulmonary artery. If the tip is distal to the proximal interlobar pulmonary artery, there's a risk of pulmonary artery rupture or pseudoaneurysm. Now, some other complications of pulmonary artery catheter placement include intracardiac catheter knot or an arrhythmia, looking at how this catheter runs all the way through the heart and then into the pulmonary arteries. These complications make sense. So in this image, you can see the pulmonary artery catheter taking its normal course through the superior vena cava, the right atrium, going through the tricuspid valve, going through the right ventricle, the pulmonic valve, and then finally finding its way into the right pulmonary artery here. Now that brings us to the end of pulmonary edema and significant tubes in an ICU admitted patient. The next thing we'll talk about is lung cancer, and I hope, as usual, you are getting value from these sessions. If you are, kindly leave a comment, give it a thumbs up, subscribe, share to someone you think would appreciate this. Thank you very much, and I will see you in the next one.